definitely, what is the word there that I have? Conversation should be modeled and practiced. Okay, so if you have someone who's autistic and you are teaching them how to count change or to be a scanner or something, well then you need to teach them how to do small talk and emulate that for them. So you would say, as you're practicing, and maybe they're doing scanning groceries or something along those lines, you would say, look them in the eye. And then you would practice that maybe. Then you would say, okay, now look me in the eye and how are you? And then, go about and then teach them the other skill, or maybe you start with the end before the beginning, depending on how you want to handle it. That would be most appropriate. But the point of it is that you've got to break it down into small pieces and allow them to have the ability to do that piece, give positive reinforcement, and then continue positive reinforcement on that until after they've taken on the second piece and they've had success with it. Then you might want to drop the first, good job, and then go to the second one. And maybe say, oh, look at, you did both of them in a row, good. That is if they can even get that far. Computer or communication board, they might really do well in music, okay? And I say, I'm not thinking of idiot savant, I'm thinking of autistic kids. Sometimes they, with you and I, when we have music, it crosses our corpus callosum and allows our right and left brain to be more interactive. But the case here is you're not going to have them be interactive. They're not going to engage, but they can do possibly music. And then that would be an area that they could utilize as opposed to rocking, or you could substitute that out. Okay. Okay. So we said that 70% of autistic children are going to have cognitive impairment. 25% are going to be borderline personality. 5% are average. In other words, they just have autism. They're going to start school as soon as the child is diagnosed in preschool years. Go ahead, I don't know, in the learning resource environment is the LRE. So you want to get them, as you see that there is a problem, you want to get them diagnosed, and then you want to get them into community services that can benefit them the most. Focus on social and communication skills, use visual skills. Higher functioning and older children might be returned to the classroom or can handle the classroom. Like I said, I had, quite a few that had Asperger's in my nursing classes. They did good, they did fine. I didn't honestly see any situation where they couldn't achieve like anybody else could. Okay, in education, let me see where we are here. Okay, what is covering that is TEACH, and it's TEACCH, is an educational approach that includes classroom teaching, parent training, and other support services. You may, or the social worker, may be the center of the team on this. And you are going to bring in the school teachers. You're going to bring in the parents. You're going to bring in other support services. And there is a method that is utilized, and it is TEACCH. And it's an acronym for, basically, I don't know exactly, but it is where you are teaching them everything that we've talked about thus far. You're assessing them where they're at. You're taking their strong points. That's going to be a leaping off for further learning. You are going to do behavior modification, positive behavior modification on them. You are going to try to normalize, streamline them, like we would with any, you're going to have to make sure if there's any other diagnoses going on, and then pull in the proper resources for that. LOVIS is another method. It's an individualized educational programming that relies on introduction, prompting, and reinforcement of a behavior, just a little bit different of a strategy. In this class, we are mainly doing positive behavior modification. These are just two other strategies that can be used. Hundreds of individual lessons to teach specific language, academic, and social behaviors. Okay, we're going to go a little bit into the LOVAS method. There's a 50% recovery rate when this is utilized. Treatment begins at 2 years of age. It's the main thrust of this is communication skill, development and skills. Picture exchange, cards and token boards are utilized. Okay, now look at this. The cost is $20,000 to $60,000 annually. You know, that's like sending your kid to Harvard. That's an Ivy League school. Some families sue the school district and win reimbursement. Why? Because the school is supposed to teach all children, right? That's a part of our constitutional rights. And so maybe the school district has to put money towards that or hire a teacher that can provide those services. Trips into the community are important. To teach the child, you know, how to act and how to behave in restaurants and in stores, how to function. And for the community to develop an understanding and tolerance for autism. That's really where we come in. You know, it's by us talking openly about it with our peers and letting them let down their guard so that they can reveal, and I don't know how to say this, but just to say it, but their ignorance to you, to us. Well, how does that work? How is that? Why is that? Well, you have to have a non-judgmental attitude towards them asking you questions so that communication can go back and forth. Why? Because if you're judgmental, you'll shut them down. And you don't want that because that's one more person in the community that will understand what's going on. Okay, yeah, we're not going to go into that. Okay. And then here's some pharmacological management. So, you know, hyperactivity, we've talked about Ritalin, if that is a dual diagnosis with them. Some of the side effects from Ritalin. Now, depending, it's different, you know, side effects have different ranges, just like, you know, everything else does. But insomnia, self-stimulation, social withdrawal, irritability might be a side effect of Ritalin. Sleep problems, and then clonidine. Clonidine is one of those drugs that has multiple uses for it, okay? But clonidine can be used for really super high blood pressure. Clonidine is also used when when addicts are coming down. They'll give clonidine to help them come down and not have such severe withdrawal problems. Okay, clonidine can be oral, transdermal, and then the side effects are drowsiness and postural hypotension. And that makes sense, right? If clonidine is given for hypertension, doesn't it make sense that if you give too much that you'll drop the blood pressure? Okay, aggression may be treated with Halidol. Okay, increased potency for neuroleptic calms without sedation. Halidol, I've given it quite a few times, but I gave it for sleep. It's also a sedative. Side effects are dyskinesia, dystonia. So dyskinesia would be difficulty with movement. Dystonia would be abnormal tone, muscle tone. Akinesia, A is without. Someone look this word up real fast for me. I'm not sure. I'm sure I wrote it down, but let me.
Dyskinesia?
What does it mean?
For dyskinesia?
Right here, akathisia.
State of attention, distress, and restlessness. That is an
Say it
occasional. A state of agitation, distress, and restlessness. That
Okay.
is an occasional side effect of antipsychotic and antidepressant drugs.
Okay, did everyone hear that? Yeah. Say it louder, George. Read it real loud.
A state of agitation, distress, and restlessness. That is an occasional side effect of antipsychotic and antidepressant drugs.
Okay. So, if they become aggressive with this, then you're going to have to play around with the dosages, right? Because if they're already hyperactive, you know, you're going to, yeah, I mean, this pharmacological intervention takes a lot out of us. Because one, we're giving it, but then now we're to look at that patient and know their baseline, and then if any of these are a side effect for them. And then if it is, we need to report it at the very least to the team, but to the doctor also. So that, you know, and notice, and you need to chart to it too. Because if they have their team meetings and it's a day that you are off, you want it reported. You want to put it. So because you're trying to have the person be the best that they can be with the use of drugs. And if one is counteracting or working against another drug, can you see how complex this can get real fast? If they have multiple diagnoses and multiple drugs, you've got to really, you are their advocate. You are the person that is helping to control everything that we can control so that they get the best out of their world. Okay, so Cogentin, we've all heard of that. Risperidone, Risperidol are other drugs that may be utilized.
Actually, I have a question.
Yeah, Benny.
Oh, yeah, but you have to.
Okay, you know how it says treatment for men's trophy? Like, what is it for? Like, that side effect, or is it for, like, the medication?
Haldol is given. Is that the one you want to talk about?
No, I'm talking about the treatment, because it says, like, treatment at the end, TX. Like, what is that for?
Oh, Cogentin. Cogentin, if anyone knows more, please speak out. But Cogentin is a antipsychotic drug. Is that the classification of Cogentin, you guys? I think it is, but I don't want to misspeak. You're shaking your head? Okay. And so, and this kind of gets back to, Benny, what I was talking about. If someone has just one diagnosis with mental health, it's really not that difficult, and especially if you know their baseline. It's when people start having multiple diagnoses, secondary and tertiary, kind of overlapping. Okay, that makes it difficult to diagnose, does it not? Where does one stop and the next one begin? And then when you go to do medication, it's even more. And that is why 60% of your job, 40 to 60% of your job is giving meds. But it's just not shuffling the meds out. It is also knowing how, if you're seeing any side effects, what's going on, how does that relate to the lab values? How does that relate to their behavior? You know, maybe you are giving Haldol for a low dosage, it's going to induce sleep. For a larger doses, it's going to, you know, for these people, calm them. But then if it starts causing dyskinesia or dystonia, you're going to want to pull off of that dosage. Did that help, Benny?
Ms. Kim.
Sort of.
For congenital.
Thank you. Okay, Cogentin, anticholinergic, antiparkinsonian is a class. It has extraparietal symptoms, disorders, okay? You guys know what those are, right? Or they might twitch or something. That it can cause that. So now you're bringing that on. You want to then lower the dosage, right? You don't want them to have an additional problem. with cardiac dyskinesia. Extraparietal disorders is another term for cardiac dyskinesia. Blurred vision, constipation, decreased sweating, dry mouth, tachycardia, urinary hesitancy, urinary retention. Okay, urinary retention can cause a urinary tract infection. Yeah, Karen?
So if I'm understanding Benny's question correctly, I think his question is cogentin the treatment for when they get the side effects?
Oh, I see what you're saying. Was that your question? Okay, thank you. I missed that one.
Because the way I'm connecting is like you give Haldol, yeah, it calms them, but the side effects are this. So now you have to give them that to treat that, right? Or no?
I wouldn't.
Okay.
I would not do that. My thoughts are, as soon as you are giving another drug to thwart the side effects of the original drug, stop. Get the whole team involved, get the doctor in there, get the social worker, the speech, get the whole team in there. Because you do not want to do polypharmacy. Why? Because there's always effects of drugs that you take. And it may not, like, okay, with cogentin, urinary retention. You don't want to cause that, right? You know, there's only so much bacteria your body can handle. And that, especially if the person's older, a urinary tract infection is going to cause them to wig out. They're going to go into dementia. Yeah?
So from my last clinical, I was in med class, but there was a client or a patient that was taking like a heart,
Medication?
but it caused like hardening stool, so then they had to breathe, like for that side effect, they put soften their stool.
Right.
So on top of that medication, they were giving more medication.
Right.
For that medication.
Yeah, and so a good team, now sometimes it's short-lived, that they'll be on like Dulcolax for softening. That's probably more, or Colase is the generic term for it, or the trade name. But Dulcolax will cause stool to be softer. It pulls moisture in. Okay, so if you're doing that, because you don't want to have an impaction on the person. I'm kind of getting deeper in this than I want to, but this is a good conversation. You don't want to cause an impaction for the person, right? Because people can go septicemic from having stool in their colon and having it just sit in there and not have the ability to expel it. So you might have them on Colase for a short time, but while they're on it, you and the person who's bed passing needs to say, here's some water. I need you to drink some water. And then when you take in the tray, you want to identify what is the high fiber on that. And now you're going to have to work with the person too. Right? Because what happens if they've got this going on and we already learned that 75% of them are going to have cognitive impairment, right? So now you've got to work with them for high fiber. If you can't work with them, well, then you're going to have to suffice with the Dulcolax, but you don't want to create polypharmacy. Because we know that Dulcolax does that, but you know what? If taken to excess, Dulcolax is going to cause a fluid imbalance because it pulls fluid into the colon from the tissue around it. So there's a lot that you're paid, the bucks that you're paid to be thinking about all of this. So you just can't go on rote memory and pass out the drugs. There's more to it than that. And anyways, cogentin is going to be a drug that if you work in this field, that you're going to give frequently. Okay? So I would say to look at these drugs, Haldol, these drugs that have been mentioned so far, you should have a 3x5 card on them and start familiarizing yourself with them. not only for professionally in your career, but also for your state boards. Okay, but Cogentin, to answer you more specifically, can be given for aggression, Benny. Okay, Haldol can be given, and then these drugs over here can also be given. There's a choice, if you will.
So it's basically like another treatment
Yeah.
for aggression.
Yeah.
Also the ones that are below it listed
Mhm.
as well, right?
Yeah.
Okay.
The Risperidone and Risperdal. Okay, some more seizures. You know, we've already talked about. We've learned that a portion of this population will have seizures. So now they're going to be on Tegretol. You know, maybe Depakote, phenobarbital, phenytoin is another word for Tegretol. And these are different drugs for seizure disorders. Typically, they start with Tegretol, but if Tegretol isn't working, then they'll go to phenobarbital because it slows down the central nervous system. It's a seconal type drug. It's a downer. Okay, self-injury, lithium is a good mood regulator, and then Texan, an opiate antagonist. If early intervention, it is promising, otherwise it's not so much for self-injury. Any questions on that? Okay, we are now leaving autism. Okay, so now we're going into cerebral palsy. And this is a disorder of movement and posture due to a non-progressive, underline that word, non-progressive, because we're going to be talking about other disease processes that are progressive, okay? My dad used to say, you know, I like being older with cerebral palsy. It's not so bad. Everyone just thinks that I had a stroke. Okay, why? Because it's non-progressive. Abnormality, progressive abnormality and posture due to a non-progressive abnormality of the immature brain. Okay, so my dad mainly had, and I wonder because he was a large baby, and they had to they delivered my dad using forceps. And I wonder if they further damaged his occipital lobe, because that is where the fine motor movement comes from. Although the brain continues to grow into early adulthood, the crucial events of its development occur during intrauterine life and early childhood. This can result in cerebral palsy and possible seizures, mental retardation, visual, auditory impairments, learning difficulties, and behavioral problems. Talk about having multiple things. These children are often small for gestational age or have malformations inside and outside of the central nervous system. So it's just not one cause of cerebral palsy. There's multiple. It can be intrauterine. It can be perinatal. Like I said, the forceps being utilized. Okay, so more causes of cerebral palsy. It can be a genetic abnormality, intrauterine infection, may damage the nervous system of the fetus, fetal hypoxia. Remember how we talked about when a woman is pregnant, it is all about oxygenation. If the mother is not oxygenating properly, then baby is not. It can be, remember we talked about RH incompatibilities, that could be another cause of it. We also learned about connectorus, which was high bilirubin levels. Is this all coming back to you? I know that they were kind of unusual terms. Okay, birth trauma, traumatic brain injury. A healthy child shows symptoms of cerebral palsy after the coma caused by an accidental poisoning or meningitis. Another cause of cerebral palsy can be shoulder dysplasia, where the shoulder is delivered first. So, you know, again, it's very important, you know, in labor that things happen, that they move. They don't move fast, but they move, they progress, and they progress in the right sequence. Okay, preterm delivery and related complications account for the majority of children with cerebral palsy. An area of the brain near the lateral ventricle is especially vulnerable to injuries at 26 to 32 weeks gestational. Okay, so mom may be exposed to a bacteria, may suffer a car accident. The blood vessels in this area bleed easily during this time, resulting in damage to the adjacent white matter, which contains neural connections important in many aspects of motor control. With cerebral palsy, it can be their gross motor movement and it can be their fine motor movement, or it can be a combination of both. Okay, high risk for cerebral palsy for infants that weigh less than 1,500 grams. Twins is another cause. Small for gestational age children are more prone to cerebral palsy. Okay, so the cortex, part 1 in this diagram, the cortex controls thought, you know that, that's the frontal area, movement and sensation. An abnormality in the movement area of the cortex can result in spastic cerebral palsy. Now we're breaking cerebral palsy down. One form of it is called spastic cerebral palsy, and that is where the injured part of the brain is the frontal area. Okay, the basal ganglia helps movement in part 2 become organized, graceful. It says an economical. That means that you're not moving. Okay, we're able to walk and glide, right? And that is a part of our CNS interacting with our brain more in the second area of where the number 2 is. Okay, so we're not spastic, or I don't want to use the word spastic because that describes number 1. When it says economical, we're not having a lot of different movements but we're able to flow, and our hands glide, and our feet move almost in a rhythm, right? These people don't have that, and the reason why they don't have it is because they've been neurologically impaired in this area of the brain. Okay, the cerebellum. Okay, the cerebellum, here's the occipital lobe. Beneath the occipital lobe is the cerebellum. That is where you have direct communication with the pons. We learned about the pons the other day. That is where a lot of the involuntary part of our being takes place. Okay, that's where we breathe. We don't have to think about it. Our pons, our lower brain handles it. That communicates right directly with the cerebellum. The cerebellum is for coordination, movement, posture, and balance. An abnormality results in ataxic cerebral palsy. Okay, this is, the ataxic cerebral palsy is what my dad had. Okay, now, my dad was a large baby. Okay, forceps were used, and he had high bilirubin. The poor guy was doomed, right? All of that going on, and he had connectorus. Where did that bile land? I suspected my father in the cerebellum. Because why do I think that? Because my grandmother reported that he acted normal until he couldn't make the benchmark of sitting up and walking. My dad was about 8, 9 years old before he was able to walk. Family didn't have a wheelchair, so they took him around in a wagon. Okay, he was born in 1925. Okay, here we have types of cerebral palsy. Spastic cerebral palsy is the most common. Okay, so looking back here, spastic is in the frontal area of the brain, so it's the most common. Spastic, okay, then we have all these terms. Okay. You need to learn these, okay. So quadriplegia is pretty easy, right? So quad 4, it's affecting the legs and the arms. hemi means half. So it is half of the body. And then diplasia is, instead of it being half, I want to say vertically, it's half horizontally. Okay, so make cards on these, make sure you know these terms, okay? But let me go back up here, now that we have the terms. Okay, so spastic hemiplegia, okay, so half, and that is going to be like the legs. It could also be the arms, typically it's the legs though. Hemiplegia, excuse me, half is going this way. One side of the body is more affected than the other side. This is where you will see someone and their gait will be something like this. They'll be able to walk on one side, but then the other side, they'll have to bring it around. They'll walk and, they'll do something to keep their balance because one side of their body, they have that hemiplegia. So they kind of have to throw that part of the body and, have an exaggerated movement. Okay. Then in spastic, okay, now what is spastic? Okay, we just learned it's the frontal part of the brain. Diplasia, here we have diplasia down here in this diagram. So the upper body is less affected, more affected is the legs. The legs are more affected than the arms. Spastic quadriplegia, all four limbs are, and then the trunk, the mouth, the tongue, the pharynx are affected. They have mental retardation, seizures, sensory impairment, and medical complications. I want to say, so we're talking about spastic cerebral palsy here, the frontal part. They have mental retardation, seizures, sensory impairment, and medical complications. Okay, here we have the different, just showing it in a different way, the different types of cerebral palsy. Okay, symptoms in the infant with CP. Excessive sleeping, irritability when awake, shows little interest in surroundings, weak cry and poor suck. Why? Because their pharynx is involved. They are, all of them, they are like a rag doll. Okay? Lie in a floppy rag doll way. Or they could be the opposite, where they're hypertonic. Okay? May have markedly increased tone and lie in an extended arch. Okay, that extended arch is what, and that is called, right here, opisthotonus. Okay, knee jerk may be too brisk or may have tremors or clonus in arms and legs. Okay, clonus is the opposite of being tonic. Clonus is weak. Tonic is where you're tight with your muscles. Okay, symptoms in children with CP. Okay, these two at the beginning of this lecture are more laborious than what we're going to learn on Wednesday. Okay, these really go into it. Okay, persistence of primitive reflexes. Okay, why? Because their tone, their muscle tone, and because their muscle tone is either too rigid, tonic, or it's too weak, clonic, then that affects their the attachment to the bone. If you don't walk properly, then your tendons are going to shorten. And with those shortening tendons, then they'll have to walk on their tippy toe. They won't be able to bring their foot down. Then that will require surgery to go in there and to cut that tendon and to elongate it. And so this is where if you have a child that you're working with, you really want to do passive range of motion. You really want to work with those tendons to try to relax them. And the best way with that is like deep heat and stimulation. Yeah.
If you have a child with CP, is a psych tech working with them more often, or are they like, do they go to like therapists such as OT or PT? More often?
You will be doing most of the care. You will be the one that will be reporting more likely than not a change. You will be the one that will be able to do the incremental therapy that is needed for that person to really have a change in their lives. We see the most change. Who really sees the most change is the nurse's aide. Okay, now more than likely you'll be working in an environment where they're not utilized that much. Who sees more change between a psych tech and an RN? It's the psych tech, not the RN. Okay? So you're going to be the one with hands-on seeing what's going on. You're going to be the one with hands-on seeing how the reaction of the medication is. Go ahead.
So are you saying that because different facilities might not utilize, because depending on where you're at, right? So
Yeah.
they utilize more PTs, and then where you could do somewhere else, they have the PT, but they also have the nurse, and they also have the nursing assistant. And
Yeah.
then some places might have all different levels, nurses, PT, nurses, nurse assistant, and then they need more specialized care, they might go to see the occupational therapist.
Yes.
And that's what you're saying?
It could be that, or it could be typically in acute means it just happened. When something just happens, like a stroke, now we're outside of the realm here, okay? We've been talking about developmental disabilities, right? Then it's going to be all hands on deck. You're going to have all the full scope of the help. You're going to have the social worker. You're going to have the PT. You're going to have the OT. You're going to have the speech pathologist. You're going to have everyone that touches that person or comes into contact with that person is going to be a part of the team and is going to have input in their treatment plan. Where you're going to see this population is after that has already taken place. And then they're going to be released by physical therapy into your care, and you're going to do the range of motion. They're going to be released by speech pathology, and then you're going to be the one with the communication board or helping them speak or doing the sign language. That's going to be on you. They're going to be released from occupational therapy, and you're going to be the one teaching them to count money or teaching whatever is needed to rehab them, to get them to be. I will tell you, I wish I knew more about this, and I did at one time, but it kind of escapes me right now. Do you know what is the best? Okay, well, we've talked about that the best indicator of a person's health is their social economic status. If they have money to do preventative medicine, then they're not going to succumb to all of these things. Okay? What is the next indicator is the intensity and the early treatment. And that's going to be on you guys. Okay? You could take care of someone with CP and probably not do too much in chart. Is that the person you want to be? You know what I'm saying? That person, they might think that they're gaming the system, but they're going to be wiped out. They're not going to have stay power. Why? Because that person's not progressing. The rest of the team knows it. And so who are the people with the greatest amount of input and time into that patient. It's going to be possibly the psych tech. And so then they're going to be relegated, they're going to be treated as an imposter, and they're not going to go. And then two, also, what makes a person thrive? A job. A job. Not only for our CP population, but for us too. That's what makes us thrive. That's what makes us, when we have a job and we are more productive and we give more, that's what makes us not only valuable to society, but valuable to ourselves, which is the best value you can have, is when you know that you've done the best. Have you ever suffered from guilt? Typically, guilt comes when you know you didn't give your all to something. And who wants to suffer from guilt? You know, that can be very debilitating. Guilt leads to a lot of mental illness, I would guess. So I don't know. I guess I'm kind of being passionate about this because I want to tell you that you're going to go into the job and some people are just going to be doing minimal. That doesn't have to be you. And by you committing to a level of dedication, you might think, oh, you know, they're kind of, I'm the joke because I'm working harder than them. No, they're the joke. Why? Because they're not going to have stay power. They're not going to have the professional accolades come back on them. And they're going to suffer from guilt. You know, I've shared with you, one area that I suffer from guilt in is when that doctor came in and didn't wash his hand and my patient got Clostridium from it. And I didn't say anything. You know, I feel bad to this day about that. But you know what? I speak up now. Because I don't want that feeling to be my norm.
Miss Kim, were you younger? Were you young?
Was I young? I was, I maybe 30, 35. I got my RN around 27, 28. So, you gotta... Okay, anyways, back to this. Some CP will do toe walking as opposed to heel walking. And what is that doing? That is shortening the tendon. Okay, because they're on their toes a lot as opposed to having that tendon get stretched when you put your heel down first. Okay, this is more with cerebellar ataxia, definitely. Why? Because the cerebral area does fine motor. Okay, symptoms in children with CP, scissor walking. Okay, that's where scissor walking is. I don't know if I can do it, but. And then they kind of throw their legs as they're going, and they have to use their body to get the momentum going. Okay, scissor gait, that it's describing their gait is the scissor. Increased tone in the muscles that control adduction and internal rotation of the hips. Does anyone know, has anyone seen scissor walking? Have you ever been in where someone is using the thrust of their upper body and then I'm trying to think of everything I need to do. I want to go on my toes and then I want to throw my body. You've seen that, I'm sure. If they have real severe scissor walking, they're usually confined to a wheelchair. Okay? Okay, associated impairments, mental retardation, visual. Okay, preemie infants might have retinopathy, right? If they had, okay, there's a gentleman at my church that is blind and has mild, in my opinion, mild cerebral palsy and autism. And so one day I was talking to him and I said, "How did you become blind?" And he said, "My mother got German measles when she was pregnant with me." And this gentleman, he's probably, I don't know, maybe 25, 27, he plays the piano. For part, not the main church service, but for the kids. And I think to myself, wow, you know, he has all this going against him and he's playing the piano for other people. Isn't that lovely? Okay, so anyways, here we have the hearing impaired rubella infection. Okay, now this was part of one of the questions on your test, right? Remember we talked about that we want to make sure that mom is vaccinated. Why? Because yes, it's protecting her, but it's protecting her offspring. Because then when she comes into contact with someone that has German measles, she's not going to get it. Her blood, therefore, is not going to have the virus in it. Is rubella a virus or a bacteria? I think it's a virus.
It's a virus.
Okay, yeah, then that virus won't communicate. Her immunity system will repel it and it won't communicate with the blood that's going to her child. If it does, and if she gets rubella, and there's that communication of blood, then the baby is going to have visual and hearing problems, yeah. And small for gestational age, be an SGA baby, yeah.
For example, okay, like my ex-sister-in-law, she doesn't believe in vaccinations, but her son got really sick, so he was in the hospital for a pretty long time. Do they get the immunizations at once, or how do they do that?
Okay, most of us, I know that all of you are immunized because you could not be in this program. You cannot go into a hospital setting unless you're immunized because above all else, do no harm. So we're all of our titers are taken for chickenpox, rubella, hepatitis, you know, all of those. There's like 5 or 6 of them, right? I don't know from what you've told me. Was she herself immunized?
I don't know, I never asked,
Okay.
but I know that
More.
grandma, the family does not believe in that. So none of her kids got vaccinated, but the oldest got really sick and he was hospitalized for several months. So my
Okay.
question was, when they're there, now that they want to get their immunizations, do they get them all at once?
Oh.
Or does that-
No, typically like how, the best example I have is like your hepatitis B. It's a 3. So you get it, and then 3 months later you get the second, and then 3 months later, 6 months or 9 months from the original one, you have to have the third one. So that they're in stages. And then if your titer drops down, then you get a booster. And then that is like and what you want, and it gets a little bit, we more than likely, although there's some foreign-born people in this classroom, okay, but typically in the United States, we have attenuated bacteria that is given to us. So it's killed, it's purified, if you can purify bacteria, that almost seems counterintuitive, but it is, and then it's given to us in our immunizations. That not all countries have the luxury of that. And so it's not attenuated. And so, you know, that can present a problem, but the risk is outweighed by the possibility of a problem. Best to have that than nothing at all. Especially when you do, I remember when I was at Loma Linda and I would go over to the health center, you know, for whatever reason, you know, a cold or, you know, to get my flu shot or, you know, something. And oh my gosh, the immunizations that it takes to go overseas. You know, you have to have a heart to really want to help. Because that would almost in and of itself prevent me from going overseas and helping. But they have to have, I mean, so much done. Because if they get over there and they get exposed, what help are they? They're of no help. Now resources have to go into them. And so when you're in a mission field, you're trying to prevent that, so you want to have, and they're immunized for, everything. Okay. We've talked about pretty much everything here. But to answer you more direct, Veronica, immunization is a set pattern, and it's not all at once.
So do they do the same sequence as the baby? You know how you
Yes.
from every month and so
Yes.
on? Properly?
They do. And typically what happens on that, as long as we're talking about it, is like the first one will give you the biggest bang. You'll get 50% that if you're exposed, you won't get it. Then the second one is 70, and typically the third one takes you up to 98%. You're never 100% secure. Okay, associated problems with CP are feeding. Okay, why? Because they can't coordinate their swallow with their tongue movement. Drooling, tonic bite, exaggerated tongue, they might have where you have to teach them, right, to keep their tongue behind their teeth and down. You might have to teach them, they might have to consciously do that. They're high risk for aspiration and choking. Okay, feeding tubes might be used. Behavior and emotional disorders, we've talked about those. They're at higher risk than the general population. Habitation, oh gosh, I really messed you up, I'm sorry. Try to get the picture too big. Okay, I have on here, goal is maximize functioning while minimizing any disability-related disadvantages, family focused and community focused. Okay, so the top line that you're not seeing says goal is to maximize functioning while minimizing any disability-related disadvantages. Definitely, we've talked about in this class that you want to utilize community resources. We're going to finish this slide and then take a 15-minute break, okay? But you want to utilize community, but try to keep them in the home. Interdisciplinary approach, and there it is, the doctor, the licensed social worker, the registered nurse, the physical therapist, the teacher, the parent, the child, the dietitian, the psych tech, the aide, whoever is going to have any care involved is needed. And in these, okay, it is all evidence-based. What is evidence-based? Evidence-based means that I hope that I have role modeled evidence-based. Okay, when George said earlier, when he said, well, the DSM-3 is more for research. Okay, you know what? Did you see how I acquiesced to that? Said, yeah, that might be. That's not my experience with it. And then Jacob said, well, and I happen to know his wife is a social worker, and he said, well, social workers will utilize the DSM-3. So obviously more than one area. Well, when you are evidence-based, it doesn't matter that I'm the teacher and you're the student, so I'm not trying to be rude, we're just talking facts here. I carry more clout than you, right? Because I'm the instructor. And so you would think that someone who carries more clout would always be right. But in an evidence-based environment, which we are, it's who's more well-read. Now, I happen to know George is a very well-rounded person. He's got a lot of different interests and things going on, and he enjoys all of that. So okay, maybe so, I said, didn't I not, Maybe, that's another area that it's utilized. My experience has been over here, but then I gave credence to George, not because I'm so great, no, because I'm evidence-based. If he has more experience in this area, then I need to, even though I'm the instructor, should have more clout, I need to acquiesce to George. And that's how these disciplinary teams are utilized. No one And it's a cool thing. When I first started nursing, like I told you, I had a doctor when I was a young nurse told me to F off. And I was just like appalled. Couldn't believe it. No one is better than anybody else because we're all bringing something to the table and we're all trying to help this person and we all have a different perspective on it. You will have more teaching in cerebral palsy than the RN will. She maybe has, if she's lucky, 10 minutes. I've been babbling now for, and we'll continue talking about it, okay? You're going to have more. And she probably doesn't even know that it's 3 different areas of the brain. And I can tell that this is coming from this part of the brain because the person has hemiplegia, and you're putting it together there in front of the team. Why? Well, you might be saying, well, we can't expect more from his legs. That's going to be the best he can give. He's got a scissor gait. You might be the one saying it's very extreme. Is there a specialized device that we can have and get for this person so that they have more mobility? I'll tell you, this mobility thing, all of us strive because it's our humanness about all of us. We all strive to be independent. Elizabeth, I'll never forget, I went one day, she was about 2 years old, and I went to help her. "No, Nana," she said to me, "I do it myself." Okay. The shirt went on, I can't remember, but inside out probably, and I was fine with it. Logan, that wasn't important to him, but boy, it was important to Elizabeth. And so I totally backed off. I remember that day as if it happened yesterday. I'll tell you, she wanted to be independent. She wanted to exert herself the same way everyone in this room wants to. I'll tell you, my dad, the day that he lost his driver's license, I saw my dad dwindle into almost nothing. That driver's license made him equal to you, to me, because he could get in the car and have mobility. But without it, he was ostracized. Behind the wheel, he looked normal and got wherever he wanted to go. And it wasn't uncommon for my dad to park and forever he was taxiing around to get out and go run the errand. He wouldn't go. When he lost his license, that was a big insult to him. So we all want to be independent, okay? Each person on this team is bringing a different perspective to give that person the most optimization that they can have so that they can experience their independence the best that they can. And so evidence-based practice is whoever has the best evidence becomes in that team the person that speaks. And it doesn't matter that they're not the doctor and that they're a psych tech or an aide. Okay? You guys are fortunate because you're in the era where what I'm saying, I remember when evidence-based practice came into being. It was about 2005, 2006. Before then, it was very hierarchical. Okay, whoever had the most degrees was the one that spoke. Whether they had it or not, and usually they didn't. Okay, then when evidence-based practice came in and patient-centered care plans, then things that was kind of de-emphasized. It had to be. This is where, and we're not in this environment right now, but what environment that is optimum, and honestly we were in this environment up until probably 2010, and it was where that science does not get polluted. That science is an endeavor for the truth. And so it doesn't matter who has what degree, it matters who has the best info to get us to the truth. Why do we want to get to the truth? Because we're trying to do interventions for this person And if those have been proven true, those are the ones that we want to utilize, not the ones just because, or we've always done it that way in the past. Am I making sense right now? Okay. So anyways, okay. Then, orthotics, braces, splints. Okay, it is not 11:05 right now. Is that the right time? I don't think it is. Yes, it is, 11:05. Okay, let's go. And I want to finish CP. And there's a lot of pictures, so, okay, let's go for another 15 minutes, see where it takes us. Someone call time on me, okay? Let's call time at 11:20. And then we'll see where we are if we go for another break or just finish it off, okay? Does that sound reasonable? Mm-hmm. Okay. So orthotics, prevention of contractures. You know that if you do not use your muscles, that you will contract. Do you know that? And then you can never get the fingers and the hands again to be relaxed and go in their normal
So
position.
you had to like get surgery at that point?
Yeah, they'll need surgery, but if you're so contracted, older people get this way a lot. You'll go to move them in bed and literally their whole body, you're thinking that you're just gonna roll them over and put a pillow underneath them and they'll be relaxed. No, their whole body, when someone's contracted. Never again. George said, can you have surgery? Well, how many surgeries are you gonna give? Yes, if it's CP and if it's a tendon on the leg, yes, you can do that. But if someone's so contracted, you can't do it. Okay, so it's our job to make sure that they don't get contracted. How do we do that? Well, we turn them in bed, we get them up, we get them moving to the best that they can, and we do passive range of motion on them. Okay, and we may need to, you guys have already learned, a part of contracture is that if a person is in bed, you can't see my foot, but if a person's in bed for a long time and they don't get up, their foot will stay like that. And then so when they go to move, they have to walk on their toes. Okay, so we've already learned how you prevent foot drop, right? You put a footboard on them or you put high top tennis shoes on them. And it only takes, this is the second time I've said this in this class, but when a person stays in bed for 7 days without getting up, that's like 7 years of wear and tear on their body. We're meant to move. And if we don't move, we're going to get contractures. Yeah.
What happens in the instance of the patient and they can't move or they're in a coma or something, a state?
Yeah.
How do the staff, how do they attend to that person?
Very good question. Excellent question. Well, one, they would put a footboard on the foot of the bed or put high top tennis shoes on it to keep them from having foot drop. Because once you have it, you always have it. Okay? Then you would do passive range of motion on them and you turn them every 2 hours, and if maybe more than every 2 hours if they need it. Okay? And if it's not done, they will get contractured. And then they'll wake up out of their coma and they'll be all, their legs and their feet, they won't be able to move.
So that would still be to bed sores, correct?
I'm sorry?
That would still be leading to bed sores.
That was what?
The bed sores,
Oh, that's independent of the bed sores, contractures. And if you're right, if you stay on soft tissue for too long, the soft tissue will erode. And it will break down the skin and eventually break it down to the bone. And then the person will have decubitus or decubiti, which is bed sores. So 2 different things happening simultaneously. Okay, so that's why we want to do braces if we have to on these people, is that we're trying to prevent contractures. Prevention of contractures at specific joints provides stability and control involuntary movement that interfere with functioning. We could use a short leg brace, a plastic splint. Have you ever seen anyone with a splint around their area here? You guys are looking at me like we need a break. Do we need a break? Okay, well, some people will wear a splint, and it straps with Velcro around their upper ankle, and it goes around their heel. And that is because they started foot drop.
I didn't know what that was.
Yeah, okay, good. And so then they'll have to put the sock on over that in the shoe, but then they won't have fluid movement the way I'm walking right now. Okay, that is going to impede. They're not going to, and so now they're a bigger fall risk. Okay, and you don't want a fall risk on top of everything else. Okay, the common resting hand splint, you've seen people with splints, open hand, thumb so that their fingers stay. If someone doesn't have any movement of their fingers, they'll get contracted. And so a lot of times you'll see the aides will roll up washcloths and put it in their hands. Roll up the washcloth, put tape around it, and put it in their hands so that they don't contract their fingers. Okay, body splints can be utilized, made of flexible porous material, controls abnormal tone. Okay, here we have examples of different types of splints. Okay, here's Peter, I was talking about, what I was trying to describe.
Okay, yeah, well, my friend said that, so now I get it.
Yeah, good. Okay, different types of pillows to keep, you have to keep people in proper body alignment. If you don't keep them in proper body alignment, that's what this is doing right here. These pillows, they'll call it, anyone familiar with the canter roll? Okay, yeah, they'll take a bed bath blanket, maybe 2 or 3, they'll roll it up, they'll put tape around it, and they'll put it behind someone's back. Because you want, when someone's in bed for a prolonged period of time, you want their shoulders to be in alignment with their hips. Okay, your iliac spine. You want that to be straight. The reason why is that if it's curved or if the person throws a leg over and doesn't sleep like that, well then you're going to cause hip dysplasia on them. Okay, and then these different wedges are meant because these people are very tonic or overly clonic, right? Their muscle coordination. Okay. Here we have to prepare the child for independent mobility. This is where PT comes in. Physical therapy, in that, not psych tech, but physical therapy PT. Because you've got to have, before you can learn how to walk, you've got to have inner body core strength to be able to walk. And so this is what they're more than likely working on with these 2 children. Okay, different types of wheelchairs. How cool is this? Multi-purpose. Okay, feeding problems helped if chair can be tilted back. Why it aids in gravitational pull of the food to get it down into their stomach. Motorized wheelchair with joysticks. Why? Because they might not have fine motor movement, and so they can control the joystick and have their hands contorted. Okay, we've all seen people, have you not seen people like this out in the community? I think we all have, right? Okay, crutches, canes, walkers, support, if they have mild cerebral palsies, look at this scooter. This is what? This is giving them that, what we all strive to have, and that is independence. That is a major, and mobility is probably one of the greatest items that contribute to independence. Okay, just showing different types of chairs that can be used, different types of strapping that can be used. You can see here, this is keeping the legs so that they're not folding. Why? Because if the legs were to fold in on one another, then that's going to affect this person's posture. This one, they're not bending at the hips. This would probably be a good candidate for a wedge. Okay, nursing responsibilities. Extended sitting can cause contractures, skin sores, decubitus. check skin, all of us. We all own skin. We own that person's skin. Keep it dry, no urine on it, no wetness on it. Use sheepskin or foam if we need to kind of pad an area. Change position, use ointments, Duoderm. Duoderm is a type of, anyone in here know what Duoderm is? Duoderm is it's like a bandage, but it's thick. And so when you utilize it, if a person has breakdown, it not only protects the breakdown, but it adds cushion. Sometimes you can have Duoderm and it will have algae in it. Algae is real good for skin growth. Okay, here's a picture of Duoderm. Oh no, that's a sheepskin. It kind of has this color, Duoderm, but not the borders. Okay, here's just different areas. Here is if they had breakdown on the elbow, on the heel. Why? Because any bony prominence is more likely to break down before other areas. Sheepskin, you can have it so that they can sit on it, provide some relief. Okay, medications for CP, surgery. Let's go ahead and take a break. It is 11:20 right now, just almost 11:20, not quite. Let's come back at 11:30. Okay, I want you to move, okay? Okay, if someone had to, real quickly, someone synthesize what we learned about autism.
What's the question?
They struggle in social settings.
They struggle in what settings?
Social
settings.
Okay, very good. Okay, I'll go for that. That implies a lot. Yeah.
They like the environment to be the same and they like repetition.
Very
like
good.
playtime.
Okay, very good. What else? Autism.
Really hard to tell if that's imagination or hallucination because of their lack of communication.
Okay, okay. Say it louder because I don't think.
Oh, hard time understanding if they're just using imagination or hallucinating because of their lack of communication skills.
I like that, but when you say hallucinating, maybe it's just me, but I think drugs. Or I think psychosis.
Or
These
psychosis?
people, yeah, they're just very absorbed, self-absorbed. But then
Yeah.
you say that, and that sounds very narcissistic, right? And they're not narcissistic though, that's just,
That's just how they're built.
yeah, exactly, that's how they're built, yeah.
They could use communication boards or sign languages.
Ooh, I like that. Yeah, very good. So you're getting more into interventions with them. Good, yeah, definitely.
Did you say they do self-soothing behaviors?
Yeah, they can. You know, the rocking is one of them, and, you know, fidgeting. You know, they'll do things with their hands. You know, sometimes you'll see them, well, I'm not even going to go there. I was going to say twirl pencils, but a lot of people do that. But they'll do things that are repetitive.
And then their diet, like Alabama said, crunchy chips.
Oh,
you know,
yes,
but-
yes. They're really keyed in to texture on food, whether it's crunchy or soft. They'll kind of zero in on one or the other.
Oh, you know, it's cool too. It's not even just food. It's even just like physical touch. Like there'll be certain type of materials and clothing that bother them to no end. too.
Okay.
So it's not even just eating. It's also touch too.
Okay. I'll go for that. That's something I didn't know, but I'll go for that. Okay, now tell me about CP. 3 different kinds.
It affects 3 different places in the brain.
Okay, good. And we'll learn those by next Monday. Yeah, good, okay. And CP, go ahead.
It affects the cerebellum, so that has to do with the balance, the movement, and motor skills.
Right, one type does.
One type.
Yeah, very good, right? Yeah, Mary.
Parts of the brain.
Ooh, I like that, non-progressive. Very good, yes. And that's going to make a difference when we get into Wednesday, okay? Because muscular dystrophies, Lou Gehrig's and all of the MS, all of those are progressive.
Yeah, it affects their speech too, so they can't really talk normally.
Right, affects their speech, for those of you that didn't hear, okay? And so we're going to use different types of devices, right, with our CP people. And that is where you guys can get really creative. You know, if you see that there's a need and you can imagine how to solve that need, you know, you might be into orthotics, and there's big money in orthotics, big money in orthotics. Okay. Let's go and talk about medications for CP, limited usefulness in improving muscle tone. Okay, dystonic, we can use sediment or carbidopa, levodopa. That is also used for, we're going to learn more about that drug, but yes, it's a drug. There's not too many drugs that can be utilized for CP. Valium, you know, right here, these drugs, you have to watch it because, you know, the risk versus benefit here, okay? Valium is highly addictive. Side effects with these drugs are, you know, drowsiness. They already drool. Do you want to have excessive drooling? When you think of drooling, we need to be thinking of aspiration, right? Of withdrawal slowly due to physical dependence on drug. Baclofen is, I think it has more to do with muscle tone. It decreases muscle tone, but the side effects are drowsiness, nausea, low blood pressure, NI. What do I have is NI. I want to check my notes here because, NI, nursing intervention. Withdrawal slowly or severe side effects including hallucinations. Okay, so NI is nursing interventions. Okay, surgery for children. Okay, what is kind of, you're not seeing it because it's under the couch there. It says CP children are susceptible to developing joint deformities. So CP children are susceptible to developing joint deformities. The most common of these result from permanent shortening or contracture of one or more groups of muscles around a joint. Okay, so that we talked about that. Okay, all of these procedures require a cast or a split. You know, they are going to require physical therapy. It's cutting through muscle or a tendon to release it so that they are able to put down their heel and walk, or they're able to extend their elbows. Attachment of a tendon on a bone, thereby lengthening the tendon. Yeah, this is a big thing. This tendon shortening on CP is something that if we don't work with them and are consistent about it, that it will happen. Okay, here it's just showing how they, you know, elongate. The tendon's going to start like this, and then they're going to splice it and sew it so that it's longer. Partial hamstring release, Achilles tendons, correction of a dislocated scoliosis is another common dual diagnosis with CP. And with scoliosis, it's where they might have to do, they call it Harrington rods, where they'll put in rods to strengthen, and that, you know, you can snap a rod, you know, so, you know, you have to watch it here, but rods and wires are used to hold the spine in an improved alignment. Bone grafts are done to fuse the spine. Until you have full fusion, you have the rods in there. And you have to be careful with the person. They can have back braces. Okay, so what is being obscured there? And it is molded, you can see molded plastic jacket to keep back aligned.
So Ms. Eastman, the rods can be removed after the spinal extraction?
Sometimes they are and sometimes they're not. Sometimes they stay in, depending on the surgery, on how old the person was, how fused the bones became. But the goal is to take the rods out. Yeah, it's called a Harrington rod, probably after a doctor. And, you know, these, we've all seen people with different, anything that is a device like this is called an orthotic. So, you know, this would be an orthotic to keep the hips in alignment with the shoulders because of scoliosis. Okay, water sports are so good. Important to strengthen muscles, physical activity, and prevent contractures. Swimming, dancing, horseback riding enhances self-esteem. I know over in my neck of the woods, there's a horse camp. I live on the east end of Hemet. On the east end, we don't have street lights, we don't have sidewalks, it's very rural. And there's a horse camp over there. And it is for developmentally disabled children so that they can get on a horse and feel and to learn how to care for horses. And that's all they deal with. They do camps all year round. Swimming is good, dancing, self-esteem, promotes belonging to a peer group. What little girl does not like horses? You know, they just are like, oh my gosh, you know, if I can have a pony. Well, these little girls are possibly feeling that way too. Here we have different items that are used. You can see this could be, you know, just a normal picture, but obviously if you are tuned in, you can see the CP there. You know, here's some computer to facilitate communication, writing, entertainment, reading. Okay. Prognosis, normal life expectancy for mild hemiplegia, about 40 years for spastic quadriplegia, 40% work in sheltered workshops or supported employment programs. You know, my story on this in reference to my father is when he was born, the doctors told my grandmother that he would live until he was about 42. My dad lived until he was either 82 or 84. He was born in 25 and died in 06. I think that he had a long life, honestly, because he got really fortunate and married a nurse, my mother. And my mother just knew what to do and how to handle it, and then all of us kids just got in alignment, and you know, probably has a lot to do with why I'm a nurse, is because I kind of just grew up with it. And then to this population, both of these, well, more so CP, because if you're spastic, you're not going to be washing your hands enough, right? And what protects them from germs, right? It's washing hands. And I grew up, like I said before, we always had a little bit of bleach water in the sink in a little Tupperware bowl, and that's what my mom washed down everything down. And then my dad had 3 normal kids, and that's it for CP. Okay, any questions on any of this? I feel really good that we got done. Thank you. You're the one that took the test, not me, and kind of put up with me. But it's 11:45. We have, I was just counting the pages, and we have just a little bit more than this for Wednesday. So we'll get on it right away at 7 and hopefully be out of here. Any questions, any thoughts on any of this? Okay, good, thank you. Done any one study guide, okay? So it just says SG plus done at this point, unless you handed me your study guide. Then I gave you the full 6 points. But for those of you that sent it to me, I have to go through my email, and then I'm gonna update it. Then I'll update your book next week, okay? And then as far as the homework that is on here, I think it's right, but I'll check it today and tell you on Wednesday, okay? And then we'll write it on the board and get that all taken care of, okay? Does anyone need this for their life scan? Okay, go ahead and come on up and get it. Yeah, that means that I haven't looked at your study guide yet, but you did do the chapter, the 2 chapters. Yeah, there was nothing due that week. Remember when we had, no, you had to do it, but it was counted beneath it or above it. Who's 29? You're 28, 20, oh, Chase, here's your, are you? Okay, here's that, okay. I was talking to someone, and they said, oh, do you realize that we only have, it was yesterday, 42 days till Christmas, and I freaked. I was like, ah!
42 days.
And so my little brain is kind of on overload. Okay, now, okay. Okay. So what we're going to talk about today, obviously, besides the title here, is we're going to talk about autism and cerebral palsy. Those are the 2 topics we're going to cover today, okay? Pretty lengthy, but we're going to get through those, and then we'll be a little bit more than halfway done, and then we'll finish up on Wednesday, okay? Does anyone in the class, have you taken care of anyone with autism? Okay, Asuri, tell us about your client, your person that's autistic.
I have family members.
You have family members? Okay, so tell us about them. Do you mind? Is that okay? How do you know they're autistic? What features do they have? What symptoms? What?
They kind of give off like they're like not in tune with everything.
Okay.
So like they do their own thing. Like if like kids are playing, they're like somewhere else doing something. They're kind of like, I don't know, not talking to themselves, but like speaking out loud.
Okay.
And then like repeating stuff that you say or repeating stuff that previously been said or they heard.
So would it be fair to say that they're not engaged with what the other kids are doing, that they're pretty solo? And then you said that they'll repeat something?
They repeat the words that you say.
Okay.
And they're very picky. They don't like certain since they have sensory problems. They're very picky with their food, like what they eat and stuff. Like my cousin, she only likes Gatorade. Like that's her that she drinks.
Okay.
Gatorade, and we have to like force her to drink water and stuff. But other than that, they're really such they're picky, they repeat things, they're very like antisocial. She kind of plays, so I have one that's 8 and one that's 23, like 24.
Was the older one mainstreamed?
No,
No?
not
Okay.
really. Like he's very active with like family and stuff. He's really like in school. He's been in like the Anderson. He went to Anderson school.
Okay.
He's been around people, kids.
Okay, okay. So, very good. I mean, that's definitely a real live example. That's going to help. How about you, Mary?
I was gonna say I have coworkers that are autistic.
Oh!
Yeah, at my job, and like she said, it's kind of, I think it's cute. Because you tell them something, and just the way they like tell you back. Like, I have this one coworker, he's on lunch, and he'll be like, he'll see my manager, and he'll tell her, oh, I'll be back at lunch in 5 minutes, okay? I'm just letting you know. And then he'll go to the thing, he'll be like, I'm punching in right now. And then he'll go and say, okay, I'm clocking in.
Okay.
Yeah, they're very like, yeah, very specific about everything.
Okay.
And when they describe stuff, it's crazy. The way
Okay.
they just specify every little thing.
There is a real, anyone else? Yeah, O'Neill.
Yeah, one of my clients was like severe autism, like a lot of rocking,
Okay.
and then he started to steer, like just steering. I don't know what he's looking at, just keep on steering wildly, like, and then a lot of touch up, like you stand up and then swing his hands and all these stuff.
Okay. So more severe here than with you, Asiri.
No, because as an adult, he still has like he makes the sounds, he rocks.
Okay.
He laughs to himself.
Okay.
He's very loud, he's in his little, they make their sound.
Yeah,
Their loud
yeah.
sound. So you have to make sure
A super wide spectrum, like Asperger's, autism. I've had a lot of, yeah, Ines.
My boyfriend actually has Asperger's.
Oh, okay. Yeah, I've had quite a few nursing students with Asperger's. And they'll come up and, self-identify to me. And, you notice slight little things, but it's not that big of a deal. They're a little bit more quiet in class. They don't, they're engaged, but they don't really overly participate. But that describes me. Sometimes I'm super participative, but typically, I know you don't believe this because I'm up here blabbing all the time, but normally I'm kind of, tight boundary. When you see me out, I very much am allowed myself to be vulnerable in class for teaching purposes, right? And also another reason I want you to see, hey, look at, if I overcame this, so can you. We're all the same intelligence in here, you know what I'm saying? That's another reason why I self-disclose. And, and honestly, another reason, I don't want you to think that I come from privilege, because I don't. It's been hard work. And I didn't have anyone pushing me or telling me what to do. Pretty much from 17 on, I've, lived outside of my home, my family of origin, and, just kind of went to school and had jobs and, eventually got married and started my own family. But anyways, that's why I disclose. But typically, I don't disclose to people. I don't really share too much. Why? Because it's just not appropriate or it doesn't come up. But so I can relate to what you're saying about your boyfriend. And I'm thinking back at different nursing students that have, self-identified with me. And I'm like, they're really bright. There's nothing lacking in that department at all. And then, other people are super shy, and I wonder, unless I hear them repeating things, if they're scared, they'll, the dog, the dog, I got the dog, and you'll just hear it over and over, and then that's kind of what cues me on, okay, typically when someone has fear and they're away from the dog, it's over with. But typically with autistic kids, it's not. Yeah, Karen?
There's this really good show called Atypical on Netflix, and it's about a kid with autism. And going to high school and stuff. It's really good.
What were some of the impediments in high school?
Like a big thing for him was dating. Like he wanted to date because his friend was dating, but he couldn't
Connect.
Yeah.
And so it made it awkward more. And that's already an awkward situation for all of us, right? Being around the opposite sex, feeling comfortable, holding hands, kissing, you know what I'm saying? Feeling like you can be a part of your own little group and then bring this person in or not. There's a lot of boundaries going on in high school with that. So that would make it tough. Absolutely. It's tough for anybody, but more so with someone who has this disability. Okay, so let's go ahead and look at it. Okay, a severe form
of a group of disorders termed pervasive developmental disorders, okay? They have impaired social relatedness. They don't relate the same way that you and I do, okay? Probably different with Asperger's though. I think that they relate one-on-one just fine. I haven't seen a problem with people who have self-identified, and like I said, they did well. Impaired in communication skills, maybe slightly because of the, with Asperger's anyways, the inability to engage in large groups. But they do just fine, like I said, with small groups. But when this broad spectrum, and it's really weird, you never really heard about autism, until about 15 years ago. Then all of a sudden, it seemed like it just kind of exploded. And with that explosion came this wide spectrum also. Unusual activities and interests. Okay, this is the rituals that they do, that they will maybe have to, before going to bed with young children, don't we have rituals? Okay, we're gonna, get a drink of water. We're gonna go to the bathroom. We're gonna brush our teeth. We're gonna read a book. And probably about an hour before that, we're gonna minimize excitement. Well, these people are that on steroids. Everything is very ritualistic, where they set things how they have to be, and it's a little bit compulsive, but it's mainly if things are out, it really throws them for a loop. And when I say out of sequence, out of boundaries, not in the right location. They appear to be brain-based neurological disorders of multiple origins and may coexist with other items. Okay, now, when someone has one disability or one thing going on, it's pretty easy to diagnose. It's when you start getting veils of things like autism with slight or moderate retardation or with attention deficit, the lines begin to blur, and it's hard for the diagnostician to diagnose more than one, more than two. Definitely more than two. You start getting into three, and it's epileptic, a little bit different because you can't miss that one. Okay, but the other ones, it makes it difficult to, is this part of the mental retardation or is it part of the autism? Okay, we've already talked about normal children. We had that. Okay, they show an interest in the human face. When mom, coos at the baby and touches the baby or strokes the baby, will move towards the mom, will, cuddle fine, will know that that is a caretaker, whether it's mom or dad, will coo at mom. They want to be held, they want to, imaginative play is really a big deal with little kids, but yet when you talk to them, they can either invite you into their imaging, or they will tell you what they were doing. But these people, someone with autism, because they don't engage fully with you, it's going to be harder for us to tell whether they're imagining it, or possibly you might think hallucinating if they're not diagnosed yet. Demonstrate preferences for speech sounds. Children, because they have heard their mom's voice in the womb, they recognize mom's voice and they project like they know mom right away. Not so much with autistic kids, that's not the case. Okay, so where is the etiology of autism? Well, it's 1 in 1,000 births. Boys outnumber girls 4 to 1. Combination of genetic and developmental factors. So it's not real clear cut. Some causes are, we talked about, if they have PKU, if they can't digest different proteins, that is a thought behind it. Untreated hypothyroidism. Okay, the thyroid is responsible for metabolism, and that is of the brain also. So that tuberous sclerosis, and this is a rare multi-system genetic disease.
It's non-cancerous tumors that grow in the brain and vital organs. Okay, so those can be identified probably under a CAT scan. Cytomegalovirus, rubella, intrauterine infections are a possible cause of it. Exposed to teratogenics, where we've talked about this, such as thalidomide. Thalidomide is that drug that I was telling you where kids were born with their hands coming out of their shoulder. It was a drug that was used, just to refresh your memory, over in Europe. It did not go through our FDA approval for morning sickness. And so they're thinking, well, maybe that was a cause of it too. If it was so extreme physically, maybe it brought on some autism. Okay, so the history behind this. Okay, so a doctor in 43 observed that some infants did not want to be held, that they in fact arched their back and almost restrained or kind of put themselves in a way to not make it comfortable for the adult to hold them, okay? That ignored or shut out any social approaches, treated people as objects. This is probably, and I want you to highlight this, treat people as objects. Okay, you and I, and this is part cultural, okay? But not entirely. I mean, we all have that, human man-kindness about us. But when we go to meet someone, don't we smile at them or try to engage them, maybe not immediately by talking, but by being, comfortable sitting next to them or walking into the room and kind of scanning the whole room? Well, these people, they don't want that. They put a barrier up. When I say these people, I mean people who are autistic. They don't want to have anyone close to them. They want to be their own silo, their own island. Okay? Infants with autism are often irritable and will stiffen when held. Okay, make sure you know that. There's a star right there. In addition, as children, they require such sameness in their environment. That's where I was talking about. Things have to be exact. They have to be very predictable. That even a minor change, repositioning a chair, can throw them off. Here it says in a rage, but they'll have to get up and go fix that chair. Can't handle it not being done. Okay, so the history among those children who could speak. Unusual features of language included parrot-like repetition of phrases, and that's called echolalia. Is that how you would pronounce that? Echolalia?
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 Echolalia? Yeah.
Echolalia, okay. Sometimes uttered long after they were heard. So this is what you were talking about, right, Asiri? Where they will repeat something and they'll just repeat it. It's like almost like it brings comfort to them that they heard it, they attached, and it's something that when, as they say it, it brings us a sense of comfort. Okay, literalness of usage and a tendency to repeat pronouns instead of you. A lot of times they'll refer to themselves. Kim like this. Kim likes Superman or Superwoman. They'll use their name as opposed to, I really like Superman or Catwoman or whatever it is that they're talking about. Play is repetitive and stereotyped with little imaging. Okay, this is what I really notice, especially with Elizabeth. So Elizabeth and I were taking the 5-hour drive from San Luis Obispo to Hemet. Well, Elizabeth at times asked me for my phone. Oh, Nana, can I put a game on here? Oh, yeah, that's sure, fine, go ahead. Other times she would sing. Other times she was chattering to one of her little friends that was in the back seat. Every now and then, at one point she said, Nana, and she asked me, is a ghost the same thing as a spirit, Nana? And, we had that conversation. And that went into, and then she would ask me, well, Nana, what about And she, on that trip, asked me about the prayer. What you pray about, Nana? She wanted to know what I prayed about. So, we went in, and so you can see that her mind, even though it was some imagination going on, some game playing going on, but it was like a little higher. She wanted to connect with me. She wanted to, engage me in conversation. These autistic kids aren't going to do that. Okay, and again, there's a broad range, and they're going to be very repetitive. I would suspect that if Elizabeth were autistic, she would have a couple little toys, and she would just play with the toys, maybe for a good 45 minutes before she would maybe take a nap or do some gaming, as opposed to like engage with me. Okay. It is a self-centered mental state in which reality tends to be excluded. They are in their own world is basically what that's saying, okay? They are in their own, and they don't want anyone else in that space. They want it for themselves. In the more severe expressions, could be greatly vary in severity. We've been talking about that, so. The child must have onset of symptoms if they're going to be diagnosed with autism. Okay, now this has to do a lot with funding. Okay, so the child must have onset of symptoms prior to 3 years of age and meet 6 of the 12 criteria listed in the DSM-4. Okay, so the DSM is a diagnostic tool that is used, and it will state in order for someone to be autistic, they must have these characteristics, and like here it said, 6 to 12, and they might list 22 criteria, and they have to have anywhere from 6 to 12 on this one. Okay, so the DSM-3, yeah. DSM-4.
They actually uses that, the DSM-4.
What's that?
They use that book when they're doing removals.
When they're doing what now?
When they're doing removals for children,
Okay.
and they look like they have an illness, they refer to that book.
Mm-hmm. It lists all of the diagnosis and all of the criteria for all of the diagnosis. Okay? And so just think, now with medicine, you have to, give me 1 second, you have to have the right diagnosis to treat a disease. If you have the wrong diagnosis, you're not treating the disease. Well, the same with mental health. You have to have a real clear diagnosis, and things have to be very clearly delineated in the DSM-4. And I think they're even up to 5 now, DSM-5. It's the addition is the last number, the Roman numeral of it. You have to be very specific with what's going on. Otherwise, how do you, if you don't have the right diagnosis, then your treatment plan, just like with Western medicine, as far as germ-based, is not going to work. Yeah, but
Yeah, I was gonna say, isn't the DSM-4 or 5 like meant for research purposes, not for diagnosing individuals?
Both. But it's used to diagnose. Do you know something different maybe that I don't know?
Yeah, well,
Please, pray tell.
For the controversy of using the DSM to diagnose individuals is that the main reason that book was written was to help for getting people to qualify people for studies rather than just diagnosing them individually.
Okay.
So that's like the main controversy with using the DSM-5.
Okay, that's the first time in my career that I've heard that. But, you might have something later and greater than I. Have you heard that, Jacob? That it's used predominantly for research and study to get people into the study that have a set criteria?
For the actual CPS workers, it's a reference book.
Yeah, that's the way. And it might be, because I'm not involved in this type of research, it might be, I'm not saying no to that.
Yeah.
I'm just saying I'm unaware of that.
I can look more into it.
Okay, and I can too.
Yeah, that sounds good.
Okay, so anyways, it's kind of the way I view the DSM is that it's more the Bible
for mental health. It really spells things out and helps with the treatment plan. And maybe research too, sounds like. Any other thoughts or questions on any of this so far? Okay, so the impact on a family, is definitely going to be there. A social worker could evaluate child social setting with the caregivers, maybe give some help, some suggestions, or maybe another setting, hopefully not. Children who are severely neglected or depressed can appear autistic. Okay, make sure you realize that. Okay, the diagnosis has to be right. So one thing you could say is, if this neglect, when did it start? Did it start when the child was after 3? Because that's when we want to start seeing the symptoms. Okay, because if they're depressed, and when I said that has to do with the money, the pot of money, the federal government will give money to people who take care of autistic kids, as they will with other mental illnesses, okay? Or elderly, or anything along those lines. Well, they want to know which pot of money to pull from. Because what happens if the child is, brain damage because of drugs? Well, that's not really mental retardation. So we want to take the money out of the drug rehab as opposed to mental retardation. Then is a child, someone might say, well, this child is mentally retarded when they're really autistic. So they want to dwindle that down to, okay, what is it and what came first? Because that is going to affect the funding for that person. I can't speak to this. If anyone else, does anyone have, my dad had cerebral palsy. You guys all know that. But I have to let you know that as a kid, I didn't really even realize that my dad had cerebral palsy until I was babysitting a little boy. And instead of babysitting him at his house, the little boy came to mine for whatever reason. And the kid was about 8 years old, which meant that I had to be probably, 12 to babysit him. And it was through that experience, he couldn't understand my dad. And I was like, what do you mean, And he started mimicking my dad, this little boy. It was innocent, but it was like, whoa, that was when it really hit me. And then I shared with you that, as I got older and my dad was abstaining from alcohol, we really had a super cool relationship. And my dad was shared with me one day that the first time he heard himself on a tape recorder, that it caused him to weep, to cry. Because everyone around him could understand him. He grew up in a small town. Everyone knew my dad. And that's how it is in small towns, right? Well, then when he heard himself on a tape recorder and he sounded so distorted, it really affected him. And, and he shared that story with me. I don't really feel like my dad's cerebral palsy had an impact as far as stressors on my family. Where it had an impact is, I think that it hurt my dad's self-image and caused him to drink. It was one of the motivators there, that he could escape with alcoholism. And that's what I really remember as a kid, was his alcoholism, not his cerebral palsy. Does anyone, Asiri, I don't want to pick on you, but how has, you said that it was a cousin. So then that would be your aunt and uncle that this child is.
Well, it's my grandma's best friend's son. And
Okay.
my uncle's son.
Okay, so that wouldn't be close enough for you to know the impact. Kind of dialogue, don't you think that would be, depending on the severity of the autism, don't you think that would be a big deal for the family? The mom's trying to hold the kid and the kid is arching its back and not responding.
Well, My family is really like family oriented, so it took the whole family to raise me.
Yeah.
So it wasn't just like my uncle raising her. It was like
Everyone
coming
jumped in.
together, helping, advice, you know.
And that's the cool thing about your culture, is that family isn't, typically in a Caucasian environment, family is who you live with. In other cultures, they're much more wider in their interpretation of family, which is a good thing, and especially in something like this, because it can be very wearing on a person to only have the immediate family participate in the care of this child.
Ms. Kim, I have a friend, she took this program 2 years ago, and she diagnosed her daughter with autism from this program. Everybody kept telling her, oh, I think you're tripping, I think she's just young. But she was like, no, more and more things that are adding up, I'm seeing it in class. So she's the same age as my daughter, and we like play, our kids play together and stuff. But she's a young mom with an autistic daughter, and it is a lot because we'll help her sometimes and she'll come over. And I see what she has to go through compared, you know?
Right.
And it's very exhausting, and it's more than just the family. Because I said, I'll help you when you need it, she's working, you know, things like that. And I said, that's good that you self-diagnose instead of listening to other people, you see the signs.
You know, as long as we're talking about it, that is one thing that I have dug about being a nurse and being in this profession, is that you're exposed to so much. And you're not only exposed to the education of it, but you're exposed to who's walking the field, who's in the trenches, who's dealing with it. And when you are that intimate with something, you can really, I don't know, it's just so, it helps you grow as a person. It helps her family. You know, I shared with you like the melanoma, you know, we had our cancer, you know, our skin integumentary, you know, and I noticed that growing. You know, I was like, wow, you know, melanoma, 4 millimeters thick, you go out and buy a coffin. You know, I was able to notice when it was in situ. That's one example. There's been numerous other examples. You know, when my husband had petechiae, it was, you know, I was like, Wayne, this isn't normal, as I'm, you know, putting my hands on his back. He's like, oh, don't worry about it, don't make a big deal out of it, we're fine. And here his platelet count was so low. You know, there's been a lot of instances like that where I am thankful that I have the background and knowledge. No, it's not right. We're going to stop and take care of this, and it sounds like that's exactly what she did. So I think that's a real benefit for us in this field. Okay, coping abilities and strategies of the family is needed. Okay, you know, I can relate to this. My dad had a hard time buttoning. He couldn't button. He couldn't put on, he couldn't tie, you know, a shoelace. So as kids, just, you know, as my dad was putting on our shoes, I remember many times just walking over there and tying them, not even being asked, just because you know what's needed. Tremendous stress on a family. I can see where an autistic child that is more extreme would be very stressful and very demanding. Did you have something? Okay. Okay, you definitely want to get involved in services with this. You want to have areas in the community where you know that you can plug into that can make a difference. So it's not that this child is just going to a daycare with other kids and not interacting, sitting in the corner rocking.
That's when because my son has that, so he has the autism.
Oh, I didn't, okay.
And then Berna has her baby too with autism. So we kind of know, you know, what we have. But, Maddie was placed in a daycare, but it was always like a one-to-one.
Yeah.
And then they transferred to school. But we started seeing more of what he was having at age 3.
Okay.
And it kind of, from there, it kind of went to, he had like a big gap where he went from being so hyper where you cannot control him over other kids to just wanting to be like
left
himself.
alone, yeah.
And left alone.
In that little bubble.
Yeah, and then like when he was a baby, the way, when I would try to help him, he would just kind of move in a way where I felt like I was gonna drop him, like,
Yeah.
you could tell right away, just put me.
Right, right. You definitely, and you know, my hat goes off to you, because now as a parent, and you're going to be teaching your clients this, okay? Now you want to get everything for that child that's going to edify that child to the maximum. And so you're going to want to make sure that in daycare that they're with, that that child is with a teacher that understands it and can deal with it, cope with it, and not only cope with it, but also educate where they can. That if they realize that things are out of place, that the teacher will not make a big deal out of it, but immediately put it into place so that that child can cope better. You're going to want to have resources in the community. What would be another resource that you could think of? I'm thinking of daycare, babysitting, the babysitters. I'm thinking of educational type things.
Speech therapy.
Speech, oh, excellent. Speech therapy.
Occupational therapy.
Yeah.
ABA therapy.
Occupational therapy, you know, definitely for CP, cerebral palsy, but possibly for this population also.
Behavioral therapy too.
Yeah, behavioral, yeah, the positive modification, you know, that we've talked about. Someone that is aware of that so that they will employ it to get the best results. Because the last thing you want to do is further isolate this autistic child, right? Put them further into their world as opposed to reaching out. Okay, supervised living arrangements may be required, you know, especially if they have a dual diagnosis or a triad diagnosis going on. Okay, we started, I'm going to go for another 10 minutes, okay, and then we'll go for a break, okay, so just to let you know. Okay, communication, language development, okay, that is the, thank you very much, the speech therapy that they'll need, severely delayed and deviant, okay? So so now you know what, that normal, by 2 years old, that child should be saying 1,000 words.
Mm-hmm.
You know, and if that's not happening, you need to investigate. Receptive language is impaired, okay, and the person may appear deaf. Important to test their vision, make sure that that's not an issue, because they might have weak eyes along with being autistic. Well, you want to, correct what you can to give them the best benefit. Maybe hearing. Okay, cooing and babbling may develop in the first 6 months of life, but then they're not doing it anymore. You know, babies love to, okay, you're shaking your head, Andre. What's Jordan? Does he coo and babble?
No, he just started using his vocal sound now, so he does a lot of like singing.
Yeah, okay, good. May respond to brief phrases, difficulty. Yeah, this is another thing with autistic. You have to be very brief and one command, typically. Sit down. I need you to look here. Look over here. You're not going to say, okay, come on in, sit down, we're going to start lecture. Okay, pull it out on your lap. You know, that's too much. They're not going to be able to follow. Do you have any experience in this? No? Okay. Okay. Okay, communication impairment, first word may be spoken between 2 and 3 years. Okay. They're going to have that echolalic rather than spontaneous. They're going to repeat, be repetitive, as opposed to with spontaneous. Personal pronouns are confused. Voice is high pitched, very rhythmic. Remain mute. Remain mute throughout. That should be life.
unable to sign or use gestures. If someone has a severe speech difficulty, you want to, that would be another community resource. You might want to start teaching them sign language and get them into a school or into a situation where they can start to learn. What do they say? They say that most kids throw temper tantrums because they can't communicate effectively. They don't know the words. And so if you can sign to them, you know, more or food or something, then they can at least communicate, and then that will keep them so that they're not overreacting, what may appear to be overreacting, but to them, of course, it's not. Well, that is going to be magnified with an autistic child. So that would be another community resource, would it not? To start sign language right away and get going on that. Would speech pathology do that?
Yes.
They would do that. Okay, that's good to know. Okay. Maybe learn better with visual rather than auditory cues. I think most of us are more visual than we are auditory. You know, communication cards, boards, sign language. You know, make sure you know this, that you're going to have to be creative and utilize these different techniques with this population. Okay, impaired reciprocal social relations. Okay, they're not going to look at you and give you that eye contact. I know that this is somewhat culturally based, but here with autistic people, children, it's going to be extreme. Okay, they're not going to want, there's a lack of empathy. So you might, I don't know, in their presence, you know, stub your toe or, you know, trip, and they're not going to rush over and help you. They're going to stay their distance and act like it didn't happen at all. Okay, you're smiling, Inez. Have you witnessed this with your boyfriend?
Well, my boyfriend's very empathetic emotionally, but he does struggle with cognitive empathy. So, like, understanding why someone might feel a certain way. Like, especially if it's not directly related to how he would feel in that situation. He has trouble understanding that.
Yeah, okay.
But things that he can relate to, he does feel a lot of empathy for others.
And part of that, okay, now we're not talking about dual diagnosis here, but part of that is, and this is going to sound sexist, but I'm going to say it anyways, part of that is that men don't show empathy the same way a woman does. You know, they're not going to respond the same way a woman. They can, but typically not. And so part of that might be related to having the Asperger's, and part of it might be related to that he's, you know, pulling his man card.
I don't know if this example would help, but when he was younger, he wanted to play with one of his schoolmates who was on a wheelchair, and he asked, like, oh, come on, let's play, but it involved something that was out of
He was going to have to run or walk?
Yeah, the other person's capabilities, and he just didn't understand that he couldn't do what he could do. So, but he just wanted to play, really. So he, like, went behind him and he pushed him out of the wheelchair because he thought, he was like, oh, well, I could walk, so why can't he walk?
Right.
But, you know, it wasn't malicious.
Right. And part of that could have been age, and part of that could have been his autism. Come on, let's play. You know, what's with you? Come on. I want it on my terms right now. Let's do it. Exactly. And he's like, yeah, I can understand where that would be tough. And so you would want, in that situation, the caregiver right there, right away, realizing that that he was autistic, so that the situation doesn't down spiral greatly. Okay, aloofness, indifference, that's what we've been trying to explain to other people, caregivers. They're not going to have the friendships that you and I have, the deep, intimate friendships. Okay, they're not, and it's not that aloofness, that bubble, that wanting their own space and the inability to totally make contact with other people is going to keep them from having those type of relationships. Okay, not seeking comfort when hurt. Does not take pleasure in social interactions or smiles. Behavioral abnormalities, a desire for the sameness, I think we really hit upon that, resistance to change, obsessive rituals. If they're not adhered to, it throws them off. Eat a restricted menu of foods. Asiri, you were talking about this. A lot of times, now this is a chemism, okay? I haven't read this, I don't know. But they're very in tune to texture of food. And if it's a different texture, out it comes. So they're not being rude, they're just being true to their autism. I don't know how else to describe it. Do you have something you could add to that?
Yeah, for my son, he always liked to have crunchy foods. So when you very crunchy, if you give him anything else, he will not eat it.
So no pudding.
No pudding, nothing.
Yeah.
And he always want it, always want it. It doesn't matter the time. When it's ready to eat, you have to make sure that particular kind of food.
When I was at Pacific High School, and one of the young men was very autistic, and I took it upon myself that he was going to have some carrots. Now that's a crunchy food. This guy didn't want carrots, but I was trying to have him eat a variety on his tray. And I got to tell you, by the 5th week into it, he was eating carrots. You have to be on it. You have to really be determined yourself. And you can't, when they give you the cue, no more, you have to back off. But then the next interaction, you have to kind of be there and kind of push the envelope a little bit. Did he ever get to where he would eat something like pudding?
Yeah, right now he's eating certain things that is out of his norm. So just as you said, if you allow them to continue eating that particular kind of food, they get stuck to it and they don't want to change.
Yeah.
So you really have to work on it.
Yeah. And this one gentleman that I was working with, I was trying to do behavior modification with him, and I didn't know if it was working. But yet I was like, okay, you're laughing, but you don't until I got into it, several weeks into it. Then I realized, you know what, it did work. And it's such a satisfying feeling. When you get it to work, it's...
Yeah, Mrs. Mann, just as you said, I just want to add...
Please, you know it better than I do. You should be up here, right?
During the behavioral modification, I learned about the eye shaping. And he doesn't like looking at people. He will not, whatever you do, he will not look at you. So one of the weekends, I took it upon myself and I used it. And it really works.
Yeah. Did you not feel totally accomplished?
I am so blessed.
Yeah. It is a blessing when that happens and you realize that you've made an impact, I can really relate, to, I don't know. Wayne and I were talking this weekend, and I shared with you that a friend came over, and it was a little disturbing to me. Some of you weren't in the room yet, but a gentleman, he came over. He worked with Wayne. He's like 78 now, so he's older, and his wife started to show signs of dementia. So he tried to keep her and, in the house. And well, one day she went after him with scissors. And he was scared because if he went to defend himself, he was afraid that the police would, he didn't know how the police would react. And so he immediately put her into a home in Hemet. And what are you going to do? You can't have someone in your home that is beating up the caretaker. And you know what I'm saying? I felt bad for him. And so he put her in a home. It's in Hemet. It's, a nice place.
And now he's on a fixed income, and it's costing him $4,500 a month to keep her there. And $4,500 a month, not, there's no holidays from that. That's every single month. And I just felt then at one point he and Wayne went downstairs. Wayne wanted to show him. Wayne has this really super elaborate apple peeler collection with all these different gears. You think, oh, an apple peeler's an apple peeler until you see Wayne's collection. Then you go, whoa. But anyways, he's got them all so that you can twist them and wind them and see, how they pop the apple off and do all of that stuff. But anyway, so they went down there and I go, oh, what did he think of your apple peeler collection? He goes, well, he just really wanted to talk. And I said, oh, what did he talk about? And he said that, he's really lonely at home. That he goes home and he liked our dog, and he is thinking about getting a poodle now because our dog talks. He'll go, and then when he would jump on me, he just jumped so lightly as to not, cause me any bruising or anything. And that would be a source of companionship for him. How did we get from that into this? People go through things, and you've got to be you've got to get really creative on it. You've got to do, and honestly, he stayed over until about 10 o'clock last night. I was tired. I did not want him to, but I had a heart for him, like, wow, he probably doesn't have people that socialize that much, because, it's hard on a family to have someone over and to, it's probably hard on you to take your son with you a lot of places, right? So you become isolated a little bit. So that would be a hardship on the family. Okay. Okay, play maybe to line up objects in a row, looking at the shiny surfaces or something that is catching their eye. Okay, behavioral abnormalities. Older children may become fascinated with schedules, calendars, number relationships. A lot of times these people, can do math, but they can't read. Okay, and it's not that they're dyslexic, it's just that they have more of an affinity ability with numbers. Intense temper tantrums can be provoked by trivial changes. Boy, don't you don't want to be scolding someone harshly for a temper tantrum when something was out of alignment. You just want to get it back into alignment, let them see, and then resume. Where with a child that didn't have autism, that might be grounds for, okay, time out. Self-stimulating behaviors. Okay, that is where the rocking comes in. Where they'll rock, or they'll wring their hands, or they'll do something repetitive. Okay? And it's just it brings them, I don't want to say joy, but it kind of curbs the, and help me out here, I want to say the isolation that they're feeling.
It's a comfort zone for them.
It's a comfort.
Yeah, a sense of comfort that we touch ourselves. Did you know that? We'll touch our face, or when someone is talking to you and they'll go to fold their hands or to touch, what they're doing, they're signaling to you, I'm feeling a little uncomfortable. I need to touch myself for reassurance. Okay? And so that is the same way that they're feeling like, okay, I don't want you in my space, but if I do this, then I don't have to, and it's not even that they're thinking I don't have to look at you, they just don't do that, because why? It's a part of the autistic criteria or behavior, and they don't reach out into your space to try to engage you. They're not going to do that. But guess what? We are, because we're going to be working with them, right? And so we have to realize that this is what we're, ground zero. And then we're going to take it from there. Yeah, sometimes they'll flap.
Spinning, toe walking, head banging, yeah, that definitely can be, especially if there's some mental retardation there. Okay, we're still talking about abnormal behaviors. They'll have a short attention span, rapid mood changes, hyperactivities. They might be real phobic. I had a little neighbor girl, this was years and years ago, we were out walking, and a dog came up to the fence and was barking kind of viciously, but we were safe. And boy, for the next 3 hours, the dog, oh, the dog. And I was like, is she phobic of the dog, or is this, and by the end of my time with her, I'm like, yeah, she's autistic. Mildly, bright girl, but something wasn't right. Insensitivity to pain or heat. Okay, I shared with you guys that my husband has a friend. We go over there and this dog bit me good. I mean, literally, I wanted to kick that dog to get it away from me because I was like, back off, dog. And he saw it, it was like no big deal. And I'm like, Wayne, help me. And because this guy acted like it was no big deal, Wayne, he was kind of confounded, like, what do I do? And I was like, I'll tell you what you do, but I am convinced that friend of his he couldn't sense that I was in fear, that this dog had just bit me, and, it's painful. And they just kept on talking about their motors and, going on about as if, I wasn't even there.
Did you show signs that he hurt you with him?
Well, that's why I wanted to kick the dog. Yeah, because, I did. I was like, oh my gosh, that dog just bit me. I can't remember exactly, but and the guy was just like, oh, no big deal. And later, later, Wayne was talking to him like, hey, dude, your dog, get your dog away. And the guy said, oh, he bites everybody. But he was just like so blah about it that I really felt like he was autistic, because obviously when someone's in distress, don't you run to them to help them? Okay, insensitivity to pain, heat, overreaction to noises, touch, or odors. The child may appear deaf to parental questions or commands, but may cover ears and scream when the vacuum cleaner is on. Okay. There's a high risk of mental retardation.
Take a break?
Yes, thank you. Yes. It is right now 9:45. Let's come back at 10. I'm going to come back right at 10?
Yeah.
I got halfway here and realized I left my phone in my office. Okay, so now we're kind of getting into that dual multi-diagnosis. Okay, so they're at increased risk for having cognitive impairment, 75%. Attention disorder with hyperactivity, seizures. Okay, they perform better on tests of visual and spatial skills and rote memory. Pretty much that's how we do most testing, so that's in alignment with that. They do poor on tasks requiring symbolic and logical reasoning. Okay, this is going to be more because their analytical skills are not as, I don't want to say in depth, but aren't at the level possibly of their age, of their chronological age. Islets of ability or splinter skills, musical skills, rote memory, jigsaw, rapid calculation, distant dates, days and dates. Okay, so they may have a spattering of these. One, maybe, that they're real good at, can be applied to developing functional skills. Yeah, that can definitely, you want to take what they're good at and use that as your leaping board for us in this room, okay? Maladaptive behaviors, they're going to be more prone to that. Increase adaptive ones, we're going to help them with that. Give positive reinforcement immediately after desired outcome. I remember with the gentleman that I was trying to have his diet be more of a wide spectrum by introducing carrots in it. Yeah, just the fact that he got them the second day with me, I was like, yay, you brought carrots back. Use small, frequent reinforcers instead of large ones. Teach child to anticipate change in an incremental fashion. Okay, we're trying to teach them flexibility, resiliency here. Stay close to the client during events that cause them anxiety. Okay, I'm thinking one day the fire alarm went off. And I was so impressed with the teacher. She immediately went to look for her students that she knew that this was going to create a problem for them. So as I saw her looking for him, then I started my look. And she says, we got to get someone in the bathroom. They need to check in the bathroom. And sure enough, there he was in the bathroom. The alarm went off. It totally freaked him out, totally created this rush of anxiety. And he was just in there rocking in the bathroom, the men's bathroom, okay? So when you are with your child or your school situation and something goes awry like that, maybe there's a loud siren, maybe a plane goes over real low. Something that you're going to filter out and it's not going to be that big of a deal to you. It's going to be a deal for them. And of course, above all else, think of safety, right? Do no harm. So you need to be on it, just like how that school teacher was. Okay, speech and language.